Well, good morning. Okay, that magically happened by itself. Great. Okay, and this is front, and that's back. Okay, excellent. Well, what I want to do in my time with you is share a bit about how one healthcare delivery system, we used to call it a hospital system, no longer a hospital system, more of a healthcare system, and even beyond a healthcare delivery system, as I hope to show you, is thinking about and using population health data. And there are at least 2 or 3 tracks to that, and it's a story that's being written or rewritten right now, in large part because the field of population health is being written and rewritten right now. Up here would be great, actually. Thanks. It's a little bit of a work in progress, and I'll tell you what we've done in the past, what we're thinking of, what we're planning for the future in terms of applying population health data to our work and our mission. So for those of you who are not familiar with Dignity Health, and you probably are if you're local, you may not be if you're from out of state, we are a fairly large organization. This slide and the data on it are a year old. We just finished our fiscal 15 year, but this will give you a sense of scale in terms of our reach. So from a hospital organization perspective, we're predominantly in California, but also have hospitals in Nevada and in Arizona. There are roughly 40 acute care hospitals and then a wide range of outpatient facilities. Last year, the overall organization was about a $10 billion operation. What I wanted to call your attention to, though, that's particularly pertinent to the conversation is that on the community benefit front, and you probably all know that not-for-profit hospitals are accountable for demonstrating and reporting certain community benefit expenditures, which take a variety of forms, including financial assistance, including unreimbursed costs of providing Medicaid, and healthcare research, health professions education, and a whole range of community-based, community-focused activities. Our community benefit last year, if you count Medicare, which the state of California request be reported, was about $1.9 billion across the system. If you take out Medicare, $1.3 billion. Of that, though, about $210 million, again, across the system, across all three states, is what I would call the more discretionary community benefit dollars, the things we can do something about that's not simply providing financial assistance when somebody shows up. These get into more proactive community-focused programs, subsidized health services that we choose to support as a community resource, the conduct of health research and health professions education. So part of my theme in my remarks is how do we maximize the value of the money under our control, in this instance, just looking at this community benefit slice, on population health. How do we have this sort of trust with the public through the community benefit accountability, through our mission to improve health, and these are some of the resources we're expending. So how do we think about doing that in the most effective way possible? And a part of that answer is a focus on population health metrics. Very briefly, these are some of this is essentially our portfolio of activities within our community health division, which sits within mission. We're originally a faith-based system. So we have an investment program, socially responsible investing. We do some ecology, sustainability related work, community benefit, which incorporates a lot of the community health improvement programs. We have 2 grants programs. There's a community grants program that is funded by 1/2% of each hospital's prior year audited expenses that goes back out into the communities. And I'll describe that process a little bit. We've got a new social innovation grant project funded at a higher level. And then we also engage in community investments. This goes to social determinants a lot, and I'll speak about that a bit more later. And we also do some global work. So that's the setup on who Dignity Health is. How do we think about population health? So this statement behind me speaks to that. Population health we see as a strategy to manage health, not just inside our hospitals and care centers, but also outside the walls through education, programs, advocacy, and other resources. And I want to talk a bit about population health from a healthcare delivery system context. There are really 2 sides to what I want to address. One is the community health needs assessment, community-focused program side of what a hospital and health system does. The other is population health management as we see reimbursement systems changing, the advent of accountable care organizations, bundled payments, and so on. So we actually hired in the past 6 months a new position as a director of community and population health that is shared between our community health, more mission-focused division where I reside, and our population health division, which is physician integration, data, risk stratification, all the clinical workflows and so on of managing a patient's care. And we wanted those, it includes care coordination, care management. We wanted those two sides to begin speaking with each other, not only at the system level, but at the facility level. And I won't say too much about that, except that it's a key part of our strategy going forward around population health. And this slide addresses the three components we see of our engagement in health improvement, but it also talks about how they are somewhat distinct. So we have the hospitals and the physicians conducting one set of activities. We've got our community health programs in the facilities, staffed with grant funds and other hospital funds, doing another set of activities with their own unique set of strengths. And then we've got our community partners with whom we're providing grant funds to, or we're just collaborating with on a variety of issues. Now, on the healthcare delivery side of things, you know, we're talking about very discrete health outcomes for a defined group of people who come to see us and receive care. We've got a lot of data on that. We can aggregate at a population level by one definition of population. But there's not a lot of connectivity of that from that side of the organization to what are the community resources, what are the social determinants of health that are impacting patients before they come in to the facility. Maybe they wouldn't have had to if those social determinants were addressed, and certainly after they leave our care in terms of sustaining those health gains. So there's a little bit of a disconnect there. And then our community health programs we see as a bridge, essentially, between the two sides. And internally, we're trying to make those walls come down a bit more and create, for the future, this slide, more of a seamless continuum across the whole continuum of our care experience and our engagement in the community. I'll tell you about a couple of concrete actions we've taken, but then I want to get back into the metric side of this. So we've hired this person. We're creating interdisciplinary teams within our facilities between the care managers, the community outreach folks, and so on. But ultimately, this is going to be both a workflow and a data IT infrastructure equation. We're going to need both. We're going to need the relationships in the organization, and we're going to need an IT infrastructure that supports that. So population health data or population health metrics, where do those reside within Dignity Health? They reside in a variety of places. Community health needs assessments have been mentioned here, and like all other nonprofit hospitals and health systems, we conduct those at least every 3 years. 25 of our hospitals are working on them now for completion in the next year, so we've got a lot of work going on right now. We've got a community need index I will share with you in a minute. That was one of our early forays into thinking about population health in a social determinants fashion. And then, of course, there's the healthcare information system side of things in terms of medical records and the aggregation of all of that in terms of procedures, outcomes, costs, quality, and the like. So the community need index is something that we created about 11 years ago. This is a partnership with Truven Health Analytics. And what we do is annually have a set of 9 indicators. I won't go through each indicator, but they're grouped into 5 areas that include income, culture and language, education, insurance, and housing as determinants of health or barriers to good health. And those indicators get updated annually at a zip code level. So one of our criteria for these indicators was that these data were available at a zip code level. And then this mapping tool is available online, free to anyone without registration, to look at an index of those factors behind good health or inhibitors to good health. There's some additional detail to this. The full data sets can be made available and so on. But we see this as a tool for ourselves. We build them into our needs assessments. We build them into our grant planning processes, but also as a tool for community engagement. and partner engagement. And we've used these maps as conversation starters locally in helping to pinpoint where are the neediest areas within a community, whether it's at the county level, the state level, highly local area with Oakland being depicted here. Now even zip code is not necessarily local enough in many cases. We know that, we've heard some of that. So this is a start, and we do maintain this as a service to ourselves, but also to others who may use it. So how do we use population health metrics? Number one, it should be self-evident if you know anything about the hospital and health system world from a community needs assessment perspective. You're collecting all of those data at least every 3 years. In the case of Santa Cruz, every year we, as participants in the community assessment project, but really driving those to implementation strategies. So what do these data say about what we should be measuring? We really need to use these data not only to set goals for ourselves, but then also as enablers to what actions are we taking and how do we evaluate the actions that we've taken. And Megan, you made reference to the lack of resources, and others did, to some of the measurement. And I think equally important to the measurement of the population health data is the evaluation side of the actions, because there's, in my experience, just so little resources put into that side of the equation where we measure things year after year. And as some folks said, those big outcome measures at a population level do not change very rapidly. Well, what can we learn about what we're not doing enough of or not doing well enough? And that side needs more research. In our community grants program, we use population data to guide our granting. Truly, the grantees or the applicants for our grants must tie their proposals back to the priorities that were in the community health needs assessments and the implementation plans that our hospitals are required to put together. So those are very explicitly focused on community metrics. We also use it for our own grant seeking as we build up resources, obviously, to address these high priority needs. And to some degree, it informs our policy advocacy, which includes social determinants frame for policy advocacy. So we do advocacy around harmful chemicals, around community conditions that do not promote strong health, in addition to the traditional advocacy issues you'd expect from a healthcare system. Stepping away from Dignity Health for a minute, these three headlines, I think, are very appropriate. These are not headlines so much as titles of documents that you may have read in the past few years that I think are very indicative of the ways in which hospitals and healthcare delivery organizations are beginning to use and incorporate population health metrics into the flow of patient care. So you've got community factors and hospital readmission rates, risk adjustment for socio-demographic factors, and capturing these behavioral and social domains in the medical record as topics that are being actively worked on right now, which will give our healthcare delivery system more intelligence about addressing those needs. And then more importantly than that, there are an increasing number of projects and partnerships that are building in the capacity then to work with these social resources so that we can begin to not only identify what those needs are, incorporate them into our decision making and care, but then also have the capacity to refer to connect people to those community assets in new ways. So I've got just a couple minutes left here, and I want to share what I think are some important factors in making metrics relevant. I think context matters a great deal. There are a lot of metrics. There are a lot of metric sets. We've heard about a number of them, and I thought I knew a fair amount about them. I've written down another 4 or 5 this morning, which is excellent. So there's not a dearth of data in a way, although there can be at the local level. But I think context matters tremendously. And looking at, say, a diabetes morbidity or mortality rate at the state or county level gets you part way, but then we need to contextualize that with what is the healthcare delivery experience with prevention quality indicators and admission rates for preventable conditions there? What can behavioral risk factor surveillance surveys tell us about behaviors and knowledge that contribute to those factors? What do we know about food desert data or the locations of fast food restaurants and convenience stores that again would contribute to those data. So if we contextualize our indicators, I think we can build a story to tell. And speaking of story, there are many indicator reports that are just that are 100 pages or 200 pages with a lot of tables, a lot of graphs, and relatively minimal descriptive and interpretive context. And to the point of purpose that's been raised a few times, I think those compendia of data are critical, but at the same time, and they have a use, but they're more as a reference document in my view, and I think we really do need to be focused on purpose and build something that is more akin to data dashboards, population health data dashboards, to get to the point of parsimony, and these dashboards may differ depending on the focus. If you're United Way, it may be very different than if you're a hospital or a health system. It may be somewhat different if you're a public health agency or some other type of organization. But if we can think more in terms of a dashboard that is aligned with some targets that we set, and there's been some discussion of goal setting, so I won't go into that. But I do think too that the indicator by itself, is not enough. There needs to be a sense of goal setting, and part of the contextualization as well is putting context in terms of quintiles or rankings. To give a sense of motivation, because data absent context really don't motivate most people. They may motivate the people in this room for sure, but without sufficient context and comparators, I think they only take us so far as part of the story that we tell to motivate action. Then lastly, I would say, relating the global indicators, what I'll call global indicators, to more practical, tangible indicators is another strategy I would recommend. Again, taking the experience of, say, a national indicator database or a countywide indicator set with one or two figures, take diabetes again, that tells us, condition morbidity, mortality at a broad level. But what do I do with that? So if we localize that, what can we learn about subpopulations? Some of this is the disparities, the differences in rates discussion that's been had. So how can we really get that to be much more localized? Then I think we jump off of population metrics, frankly, and begin to get into the performance metrics. So if we know enough about a problem at a global level, at a localized level, at a subpopulation level, and we certainly would be able to build trend data around most of these indicators that have been around for a while, then I think we need to begin looking at performance metrics that speak to what are the performance goals for what we think we can change at a zip code level, at a neighborhood level. It may not be the whole population, but if we can demonstrate results for 100 people, 1,000 people, 10,000 people at a time, we can begin to make some progress. So I think the evaluation side and the performance improvement process side of these population health metrics is also key in terms of making them metrics that matter for action. So thank you.
Thank you.